Apology. All right. Okay, let's get started because we've lost some time. So I think probably this group is pretty well aware of why we want to focus on prevention in ovarian cancer. So often ovarian cancer is diagnosed in advanced stages. It's largely asymptomatic until it is already in advanced stages. And many patients are diagnosed in third or fourth stage, which means that survival rates are much lower than we would want them to be. And unfortunately, we still have no effective way to screen for ovarian cancer. And so, given all of this, prevention really makes a lot of sense. And of course, primary prevention, stopping a disease before it has even started, is often something that we should strive for. And this became possible with high-grade serous ovarian cancer when we began to better understand the disease. So about 20 years ago, we began to understand that ovarian cancer, epithelial ovarian cancer, was not a single disease, but it was actually 5 distinct histotypes, so 5 different diseases. And these diseases have different tissues of origin. And the most common and the most lethal form of epithelial ovarian cancer is high-grade serous ovarian cancer, which represents 70% of ovarian cancers and about 90% of deaths from epithelial ovarian cancer. And it was actually through the careful study of fallopian tubes removed during risk-reducing bilateral salpingo-oophorectomy in people with BRCA pathogenic variants that we began to understand that the tissue of origin for high-grade serous cancer was the fimbriated end of the fallopian tube and not the ovarian surface epithelium, as was previously believed. And this meant that there was an opportunity to prevent many high-grade serous ovarian cancers. And so Dr. Diane Miller, who you can see on the screen here, really led a charge and a practice change in British Columbia. In September of 2010, the ovarian cancer research team led by Diane recommended to all BC gynecologists that they undertake complete bilateral salpingectomy at the time of hysterectomy, which is removal of the uterus, and instead of tubal ligation for people seeking permanent contraception. And Diane started calling this opportunistic salpingectomy. And the reason that it was called opportunistic salpingectomy is to reflect the fact that it is based entirely on a surgical opportunity to provide ovarian cancer prevention. So opportunistic salpingectomy, as we practice it, has absolutely nothing to do with an individual's level of risk for high-grade serous cancer. It is entirely based on having a surgical opportunity to provide ovarian cancer prevention. And so this is just a little picture that sometimes I like to show just to be really clear of what we're talking about in terms of anatomy here. So what you just saw was a salpingectomy, so complete removal of both fallopian tubes. A hysterectomy, removal of the uterus, used to leave both fallopian tubes and ovaries behind if the ovaries were being conserved. And tubal sterilization, as we used to perform it, was an occlusion of the fallopian tube. So the permanent contraception came from the fact that the fallopian tubes, which their role is to move sperm and egg to the uterus for implantation when a person desires a pregnancy, this occlusion would stop that from occurring, but the tissue was left behind. And of course, what we're talking about now with salpingectomy is, as you'll see again in a second here, complete removal of both fallopian tubes. And we do this a lot in British Columbia. So this started here in BC. We were the first jurisdiction to make these recommendations, again, really led by Diane and others in OVCare. When Diane made these recommendations and when the educational campaign went forward, gynecologists really dramatically did change practice here in BC. And you can see that in 2008, this really was not occurring at hysterectomy or at the time of permanent contraception. very frequently, and now it is by far the dominant approach when it comes to these surgeries. And we've done a lot of research here in BC, Janice and I and others, to look at the safety and the effectiveness of this approach in terms of making sure that we're not increasing risks for any postoperative complications, any perioperative complications. So you can see there's no increase in length of stay in hospital, hospital readmissions, blood transfusions, or bleeding. There's no increase in minor complications occurring post-discharge. The only thing we've ever seen is a slight increase in the likelihood of filling a prescription analgesic in the 2 weeks post-discharge from hospital, but this completely disappears by 1 month post-discharge, and we expect it's more of a just-in-case prescription that providers are giving folks. And then we still have, we don't have any suggestion that this reduces the age of onset of menopause. So the ovaries produce hormones, the fallopian tubes do not, but there was some concern that removing the fallopian tube may somehow reduce blood flow to the ovaries, which may reduce the age of onset of menopause. Our data does not show this, nor does any other data that has been published to date. And we've also shown it's safe to do at the time of a cesarean section for people who do not want any future pregnancies. We had a previous paper that was published in 2022 that showed 0 high-grade serous cancers in the opportunistic salpingectomy group, and this was with follow-up through to the end of 2017. And I'm going to show you some updated numbers today to give you a sense of how much we think this reduces risk for high-grade serous cancer. But before we do that, I just wanted to point out that while this started in British Columbia, this has really become a worldwide international practice change. So there are now actually 24 countries that have official recommendations for opportunistic salpingectomy. So between 2010 and now, what started in BC has really become worldwide practice. So what do we know about the amount of reduction in risk that somebody gets from removing both of their fallopian tubes? And again, remember, these are people at average risk for ovarian cancer. So this is not in a high-risk population. We've looked now at 45,296 people who had comparison surgeries. So those are folks who had hysterectomies with their ovaries conserved. So they had their ovaries and fallopian tubes left behind. Or people who had some form of tubal occlusion for permanent contraception. So their tubes were occluded, as that video showed, and not completely removed. And we compare them with 40,520 people who've had their fallopian tubes completely removed at the time of their hysterectomy or for permanent contraception. And when we have follow-up through to the end of 2020, we can see here that there is a hazard ratio, so a likelihood of getting high-grade serous ovarian cancer that is reduced by nearly 80%. And this is what we call in research statistically significant, which means unlikely to be explained by chance. So it looks like removal of both fallopian tubes can reduce an individual's risk for high-grade serous cancer by nearly 80%, which is really significant in medicine. We don't get that kind of risk reduction very often. And so we wondered if maybe this could be explained by differences in these groups. So differences in risk and protective factors for ovarian cancer, for example. And so we looked at many of those risk and protective factors, and you can see that these groups look very similar in a lot of these things that we know are important in predicting an individual's lifetime risk for high-grade serous cancer. So they have the same number of live births, the same number of pregnancies, which, as many of you likely know, births and pregnancies are protective for high-grade serous cancer. There is a little bit more use of combined oral contraceptive pills in the opportunistic salpingectomy group, but the actual total days of use are more similar, and that's what really matters in terms of risk reduction, is use of combined oral contraceptive pills for 5 years or more really significantly reduces risk for high-grade serous cancer. And there's a little bit more endometriosis in our opportunistic salpingectomy group, which is a risk factor for the two next most common forms of epithelial ovarian cancer, but not high-grade serous cancer itself. So we figured that it didn't really seem like these differences in risk and protective factors could explain such a large risk reduction. So we wondered, is there something that we can't measure that's different about these groups? So is there something about the salpingectomy group that makes these people more interested in cancer prevention? Are they, seeking out ways to reduce their cancer risk writ large? Are they healthier? Is there something that we can't see in our data that could explain this? And to answer that question, we decided that we would run the same analysis, but we would use breast cancer as the outcome. Because if there was some unmeasured difference that made this group less likely to get cancer, we would see the same relationship with breast cancer. And what you can see here is that there's a hazard ratio here of 0.99, which 1 means absolutely no difference. So 0.99 is essentially identical to 1. And so there is no relationship between salpingectomy and breast cancer. So this just makes us feel a lot more confident that what we're seeing with that hazard ratio of 0.22 really is the risk reduction that we get from removing both fallopian tubes. And so we also looked at the histotype distributions in these groups. And you can see here, if you've ever seen a histotype distribution chart for epithelial ovarian cancer before, this is what it looks like when you look at a historical chart that has thousands of cancers over many, many years. It's really dominated by the dark blue, which is high-grade serous cancer. It's the most common form of epithelial ovarian cancer, followed by endometrioid and clear cell as the next two most common types, with a little piece of the pie for mucinous and low grade. So the comparison group looks exactly the way we would expect them to look, even though this is a relatively small number of cancers, because again, we're talking about a relatively small and quite young group of people. But you can see how significantly different this pie chart looks for people who do not have fallopian tubes. So this part of the pie chart that is high-grade serous cancer is very, very small. So again, this just reinforces that something is different when we remove fallopian tubes, and that difference is that the risk of high-grade serous cancer seems to go down considerably. And so, this is really good news for BC. And you can see here that there are many other provinces where uptake is quite good, particularly at the time of hysterectomy, but there's definitely room for improvement. So if we really want to use salpingectomy to its greatest benefit, we have to make sure that all patients are being offered salpingectomy when they undergo these surgeries. And you can see that there's even more room for improvement when we're looking at tubal permanent contraception. So we don't want to see yellow. Yellow means, there's not a lot of uptake. And you can see this map get darker between 2017 and 2020, but we'd really like to see a lot more purple on this map. So there's work to be done just to make sure that all Canadians are being offered salpingectomy when they have these gynecologic surgeries. And the other thing that we think about a lot when it comes to salpingectomy is that we need to, if we think we have a safe and effective prevention approach for high-grade serous cancer, then we need to offer this in more opportunities than just gynecologic surgery alone. And one of the reasons that's especially important is because fewer and fewer people are choosing tubal permanent contraception as there are now more contraceptive methods available to people. So, for example, many people are choosing to use a hormonal IUD as their contraceptive choice, instead of undergoing tubal permanent contraception. So not only do we want to offer it more broadly to reduce the risk for high-grade serous cancer in as many people as possible, but we're also losing our opportunities to perform it during gynecologic surgery because we're doing less gynecologic surgery. And so we opened a clinical trial. I mean, myself and Dr. Carl Brown and Dr. Heather Stewart, in British Columbia, doing this during colorectal surgery. And what we've learned is that people really want this when you counsel them properly. So we did not randomize for this trial. We didn't feel there was clinical equipoise. We gave people the information and we let them choose whether they wanted to be in the intervention group or the control group. And you can see here that we cannot recruit to our control group to save our life. So everybody is choosing the intervention group, because when you explain this to people, they overwhelmingly choose this as their option. So we've now pivoted to using retrospective match controls, because we'll have to keep the trial open for 20 years to recruit enough people at this rate. And that the colorectal surgeons can successfully do this on their own. So they've successfully removed both fallopian tubes in about 90% of patients. And it has also been very safe. So these are the safety outcomes that we've looked at. There are no differences across these groups. There are no safety signals to be concerned of. And the process outcomes also look great. So it's actually only taking them an average of about 4.5 minutes to do this in the OR. So again, just, more ways that we can reduce risk for ovarian cancer in the general population by expanding to general surgery. And there's been 2 recent studies that have shown the potential impact of this expansion. One has come out from Johns Hopkins and another from the Mayo Clinic, and they examined the proportion of high-grade serous ovarian cancer patients who had a previous surgical encounter where OS could have been performed but wasn't. And they reported 25 to 57% of their high-grade serous ovarian cancer patients had missed an opportunity to have their fallopian tubes removed prior to their ovarian cancer diagnosis. So that just suggests that there's the potential to make a real difference here if we can use salpingectomy to its greatest benefit. And this is what you can see here, is that many of these missed opportunities were gynecologic, but the next most common was general surgery. And this graph on the right really shows that gynecologic surgeries occur a lot in younger women, but once we reach the age of 45 and above, the most common surgical encounters are with a general surgeon. So we really do want to expand and work with our general surgery colleagues to provide as many opportunities for fallopian tube removal as possible. And we're doing this right now in BC. We have a campaign underway right now with the general surgeons. And, you may be thinking, well, if this is safe and effective, shouldn't we also be targeting people who are at higher than average risk? And that is definitely something that we are also spending a lot of time and energy thinking about and researching. So we actually have tools that are clinically validated to measure an individual's lifetime risk for ovarian cancer. And we have pretty good data to say that anybody with a 5% lifetime risk or higher, it makes sense to offer those people a risk-reducing salpingo-oophorectomy. So fallopian tubes and ovaries removed at 5% lifetime risk or higher. But what about people who are in a more moderate level of risk? So maybe somewhere between 2.5% and 5% lifetime risk. it likely will make a lot of sense to offer those people a risk-reducing salpingectomy. So they will get to keep their ovaries, but have their fallopian tubes removed. And we expect that that could prevent a significant number of high-grade serous ovarian cancers. So we are doing work on that right now. And just to also say that, you know, the tubes are really having a moment. People are beginning to understand that the fallopian tubes are really important in terms of ovarian cancer genesis and thinking about what we can do, you know, with fallopian tubes to reduce people's risk. And so I will stop there. But yes, just to say that what we've learned about opportunistic salpingectomy in people at general population level risk is that it is a safe and effective way to reduce risk for serous cancer. We really need to be offering this in all pelvic and abdominal surgeries where it's safe to perform and where a person wants it. And we are beginning to consider the role of targeted risk-reducing salpingectomy.
Thank you, first of all, to Inspire Health and BRCA and BC for the opportunity to speak tonight, and to all of you in the audience for your interest in this topic. So I will acknowledge that the land where I usually work and live belongs to the Musqueam, Squamish, and Tsleil-Waututh peoples, but I'm currently on the lands of the Mississaugas of the Credit, covered by Treaty 13 in Toronto, and I believe Dr. Hanley is here as well. Now, you're all familiar with this, but this is just to set the stage. Those with an inherited mutation or pathogenic variant in one of the BRCA genes have a very high lifetime risk of breast and ovarian cancer. Now, this talk tonight will focus on ovarian cancer risk, which is between 40 and 50% for BRCA1 and about 15 to 20% for BRCA2. Now, in the year 2025, despite all of the advances in technology, imaging, and biomarkers, as you heard Dr. Hanley say, we still do not have an effective screening test for ovarian cancer, and therefore the only strategy proven to reduce the risk of ovarian cancer in these high-risk individuals is risk-reducing bilateral salpingo-oophorectomy, or surgery to remove the ovaries and fallopian tubes. This is recommended at a young age to avoid the onset of ovarian cancer, which tends to be at a younger age than ovarian cancers that are not related to BRCA. And as you may know, risk-reducing salpingo-oophorectomy is recommended for BRCA1 carriers between the ages of 35 and 40, and for BRCA2 carriers between the ages of 40 and 45. This recommendation is the same, regardless of ethnicity or socioeconomic status. And as many of you may know, Angelina Jolie made her personal story very public in 2015 when she was featured on the cover of Time magazine because of her decision to pursue risk-reducing bilateral salpingo-oophorectomy at the age of 39. But we all know that this risk-reducing journey is not easy. Risk-reducing bilateral salpingo-oophorectomy at a young age causes premature menopause. And so what is supposed to happen naturally and gradually around the age of 50, all of a sudden happens at the age of 35 to 40. There are numerous short and long-term health effects that occur immediately after premature surgical menopause, which basically affect every part of the body, as you can see on this diagram. Now, one way to overcome or mitigate these health effects is to use hormone replacement therapy, specifically estrogen, to replace what was normally being produced by the ovaries before they were suddenly uprooted and extracted from the body. But the use of hormone replacement therapy is low in those who become prematurely menopausal, at least in the province of British Columbia, but we have no reason to expect that it would be different anywhere else. So a few years ago, we conducted this population-based study using PharmaNet prescription data and looked at patients who had their ovaries removed before the age of 50. Now, only about half of them had ever used hormone replacement therapy, and most of them for less than a year. Now, this study wasn't able to get into the details of why hormone replacement therapy was not used, but it may be a combination of factors, perhaps healthcare providers not knowing that it's safe to prescribe, particularly for a BRCA carrier, patients being concerned about the risk of breast cancer, and unawareness or dismissal, or what we call optimism bias, of the harmful effects of estrogen deficiency in the long term, particularly osteoporosis and coronary artery disease. So these individuals may be aware of these conditions, but they think they happen to other people and not themselves. So in general, hormone replacement therapy, even for a short period of time, is safe for those who have a BRCA mutation. But this requires an individualized discussion based on personal circumstances. So how to mitigate or reduce these health consequences of premature surgical menopause after risk-reducing bilateral salpingo-oophorectomy? Well, there's what I call front-end mitigation, where you prevent premature menopause from occurring altogether, or back-end mitigation, where you deal with the health effects of premature menopause. So let's start with back-end mitigation. Many of you may be familiar with my colleague, Dr. Lisa Dawson. She and I started the Gynecologic Cancer Survivorship Clinic in February 2021, in the midst of the pandemic. And this was intended to provide tailored counseling around hormone replacement therapy to those having risk-reducing surgery for hereditary cancer syndromes. Now, since the clinic was opened 4.5 years ago, the clinic has recruited over 600 patients from around the province. The vast majority of patients who are eligible for hormone replacement therapy have ongoing use of this sustained for years. So that's great for those who have access to this service. Now let's look at front-end mitigation, where we prevent premature menopause from occurring in the first place. In 2013, we were actually the first to publish this study that predicted that salpingectomy, or removing the fallopian tubes first, followed by a second surgery for oophorectomy, or removing the ovaries at a later date, would be effective and cost-effective. And we made this prediction based on emerging evidence that the majority of cancers diagnosed in individuals with a BRCA mutation were actually high-grade serous carcinomas arising in the fallopian tube and not the ovary. So we hypothesized that by removing the fallopian tube first, which is the organ at greatest risk and not involved in hormone production, we could prevent early menopause but still offer protection against ovarian cancer. But it was still going to be important to remove the ovaries at some point, perhaps closer to menopause, for two reasons. Number one, not all high-grade serous carcinomas arise in the fallopian tube. The majority of them do, but there are still some high-grade serous carcinomas that arise in the ovary. So it is going to be important to remove the ovary at some point. And secondly, some patients, particularly those who have a BRCA2 mutation, may have their breast cancer risk reduced if the ovaries are removed before menopause, because removing the ovaries before menopause reduces their circulating estrogen, and many of the BRCA2 associated breast cancers are estrogen receptor positive, in contrast to those who have a BRCA1 mutation, who are more likely to get the estrogen receptor negative cancers, or triple negative breast cancers. So we created this sophisticated model based on the best available data to estimate the ages at which salpingectomy and then delayed oophorectomy should be done as a two-stage surgical procedure that would be comparable to the one-stage standard risk-reducing bilateral salpingo-oophorectomy. So we found or estimated that the earlier the salpingectomy is done, the earlier you remove the fallopian tubes, the later you could delay removal of the ovaries in order to achieve the same risk reduction against ovarian cancer compared to risk-reducing bilateral salpingo-oophorectomy at an age somewhere in the middle. So for example, if salpingectomy is done at the age of 35 and oophorectomy is done as a second operation at the age of 50, that achieves the same protection against ovarian cancer as having both ovaries and fallopian tubes removed at the age of 40. The advantage of the two-stage surgical procedure is that it can delay the onset of menopause for maybe even up to 10 years. But the disadvantage is that it requires 2 surgical procedures. Now, our results were actually recapitulated by our colleagues in the Netherlands who did the same kind of analysis 3 years later, and they came up with essentially the same results. So early salpingectomy and delayed oophorectomy could yield the same risk reduction as risk-reducing bilateral salpingo-oophorectomy at an age somewhere in the middle. So for example, if you had your fallopian tubes removed at 33 and the removal of the ovaries or the oophorectomy at age 43, this would offer the same risk reduction as having the ovaries and fallopian tubes removed at the age of 38. So again, the two-stage surgical procedure allows for delaying the oophorectomy and menopause, here in this case for about 5 years. But these are just statistical models, and the extent of risk reduction still has to be confirmed in real life. Now, there will never be a direct head-to-head comparison of front-end to back-end mitigation, but this study from the Netherlands surveyed individuals who had undergone either strategy, and they found that those who had the standard risk-reducing bilateral salpingo-oophorectomy had less sexual functioning and more sexual distress compared to those who had the two-stage surgical procedure. And then the figure on the right, I don't expect you to be able to read all of that, but what this shows is that there are a number of menopausal symptoms that the individuals were surveyed about, and the study found that those who had the two-stage surgical procedure represented by the dark green bars were far more likely to have none of those menopausal symptoms compared to those who had the standard risk-reducing bilateral salpingo-oophorectomy, even with hormone replacement therapy. And as expected, the majority of individuals who had risk-reducing salpingo-oophorectomy and did not use hormone replacement therapy experienced menopausal symptoms, and they're represented by the orange bars. So now there are at least 3 international studies examining the effectiveness of the two-stage surgical procedure compared to standard risk-reducing bilateral salpingo-oophorectomy, and 2 of these studies are open in Vancouver. The first is the SoROCk study, which is run by our colleagues in the States. So the SoROCk study is intended for BRCA1 carriers only between the ages of 35 and 50. They have to have a CA-125 blood test and transvaginal ultrasound first, and assuming those are normal within 6 months of the planned surgery, then they can actually choose which surgical intervention they'd like to have. They can choose to have the bilateral salpingectomy first, and then they have an annual follow-up with CA-125 blood test, and then ultimately have the bilateral oophorectomy or removal of the ovaries, and they continue to have an annual follow-up with CA-125 until the study ends, which is supposed to be about 20 years from now. Or they can choose to have the standard surgery, the bilateral salpingo-oophorectomy, and still have the annual CA-125 until the study ends. Now, patient-reported outcomes, including quality of life, are collected before and after the surgery. And there are now 521 centers that have this study available worldwide. We were the first Canadian center to open, but I'm happy to report that a second center is opened now in Montreal. But we are one of the top 25 sites in the world in terms of recruiting number of individuals to the study. And as of September 2025, just under half of the targeted accrual was achieved. So these are the local SoROCk study results compiled by our research coordinator for the study, Max Trocchici, who many of you may have met already. The study opened in Vancouver in May of 2024, so that's just 18 months ago. But since then, we've recruited 29 patients. You can see that 13 of them have undergone the standard bilateral, risk-reducing bilateral salpingo-oophorectomy. 15 have undergone bilateral salpingectomy with the intent to have the oophorectomy at a later date, and one patient withdrew from the study. But in terms of adverse effects or complications after the surgery, there was one who had a hemorrhage after surgery, which was associated with a hysterectomy that was done at the same time, and that patient required a second operation. But only 3 others had adverse effects that were likely associated to becoming menopausal at an early age. There was one patient in the salpingectomy arm who experienced hot flashes after surgery, but the severity and the duration are unknown. And so far, none of the patients we have recruited to the study have developed a cancer since the surgery. Now, this is the second study that you may be familiar with, called the TUBA-WISP study, which is conducted by our colleagues in the Netherlands. Now, the TUBA-WISP study is very similar to SoROCk, but it casts a broader net, and it allows individuals with BRCA and other mutations to be recruited. The other differences are that there are specific ages at which the second surgery should be done for those who are choosing the 2-stage surgical approach. And the annual update doesn't have to include a CA-125, but should at least include a televisit with one of the TUBA-WISP study team members. And follow-up is expected to go on for another 10 years, so this study could provide an answer sooner than SoROCk. Now, this is from the TUBA-WISP website. It highlights the countries that are involved in the study. And so like SoROCk, this is an international study. And again, Vancouver is the only center in Canada to have this trial available to patients. Now, it wasn't us who put this map together, but they've put Vancouver in the middle of Nunavut, which is arguably the center of the country. Now, this is a short summary of our local TUBA-WISP patients, thanks to Kiana Buran, who's the research coordinator for this study. We opened this study 10 months ago, and we've already recruited 16 patients. Now, in this study, the majority have chosen bilateral salpingectomy with the intent on delayed oophorectomy. There have been very few complications or adverse effects. Only 2 had experiences that required a visit to the emergency department, but not any further surgical intervention. And then finally, the last is the Protector trial. Now, this is a trial that was only accepting patients in the United Kingdom. It allowed individuals to choose one of 3 strategies. They could choose to have the standard surgery, risk-reducing bilateral salpingo-oophorectomy, or the 2-stage surgical procedure, or no surgery. And this study has recruited 1,150 patients so far, and at the present time, it's not enrolling any more patients. So in summary, less may be more. Salpingectomy removes the organ at greatest risk for ovarian cancer while preserving quality of life by preventing premature menopause. For those who choose salpingectomy first, oophorectomy still needs to be done because the ovaries are still at risk of developing cancer. Not all of the cancers arise primarily in the fallopian tubes. There are still some of these cancers that can arise in the ovaries. So we feel it's still critical to have the ovaries removed at some point. And particularly for those with a BRCA2 mutation, there may be some protection against breast cancer risk. And finally, if you have a BRCA1 or 2 mutation or other hereditary cancer syndrome, please consider participating in one of these clinical trials. I feel that the best take-home message is visual, and it's this: please don't try this at home, unless your home is Vancouver. So while this surgery is a straightforward laparoscopic day surgery that any gynecologist can do in the community, we urge you to think twice before asking your local gynecologist to do this operation. First of all, we don't actually know if the 2-stage surgical procedure is just as effective as standard risk-reducing bilateral salpingo-oophorectomy. It has to be proven in a clinical trial where there are standardized inclusion and exclusion criteria. Surgery and pathology are done where there are very specific protocols about examining the entire fallopian tubes under the microscope by an expert gynecologic pathologist, and there has to be long-term follow-up afterwards. Because what if we're wrong? I mean, I don't think we are, but if these surgeries are being done in the community and no one is systematically collecting the data, how will we ever know if or when these patients develop cancer post-surgery? So we have seen patients from all over British Columbia for these trials, including a few from the island. So they only need to come to Vancouver once for consultation, consent, and surgery. And for those who live far away from Vancouver, we try to coordinate that visit so that the consult and the surgery are done within a couple of days of each other so that it limits their stay in Vancouver. And then they can have all of their follow-up at home. It can be conducted by televisit. So that brings me to the end of the presentation. Thanks very much for your attention, and I'm happy to take questions.